Okay. Yes, am I audible and the screen is visible? Yes, am I audible and the screen is visible? It's echoing. It's echoing on my side. Right, so your doubts and queries are welcome, but meanwhile, let me start with asking some of the questions. I'll keep on asking some of the questions in between. So I have two, three screens open in front of me. So you have to answer what kind of instrument is this. Great, the chat is open in front of me. Okay. So you have to check what kind of instrument is this. So these are the options. That is the question, and these are the options. Any one of you, please. So that's a simple one actually. That's a Belfour retractor. That's a Belfour retractor. That is used for abdominal surgeries. That is used for open abdominal surgeries. Belfour retractor. Belfour retractor. Fine. That's used for open abdominal surgeries. Fine. Okay. So now we move to the second question. You have to identify this instrument. There's some lag. There is some lag, I believe. Dr. Sunil Jha, Dr. Prince Singh, Dr. Brain Fruition, a nice name by the way. Tausif Khan, what kind of instrument is this? Yes, so that is a Baker's dilator used on bile ducts. Baker's dilator used on bile ducts, right? Come on, guys. I believe that has already been conveyed to you that it is an interactive section. This is an interactive session. Fine. So your doubts, your question, your queries are welcome. Fine. So we are there to solve your doubts and queries. Fine. That's an interactive session. Please keep in mind. Fine. So your question answers, they are welcome. Keep on asking some of the questions. Right. You know, if you don't ask otherwise, then I'll keep on asking questions. Okay. So again, you have to identify this instrument. You can see there's a hollow there. There's a hollow there. One. Second thing, you can see there is no lock. There's no lock. Fine. And that's just one screw is there. No box. These are your options. You have seen this instrument in the previous class. You have seen this instrument in the previous class. Fine. This instrument you haven't seen. And the instrument is this. This is the answer. This is the answer. Now I'll start asking questions by name now. Dr. Samir Khan, you are there. Dr. Samir Khan, Dr. Sunil Jat. Next question you will have to answer. Please try to answer this question. Dr. Devashish Man, wherever possible, CT will always be better. CT scan will always be better than any crude investigation. See, barium is based on barium. Barium is based on X-rays. You take the X-ray slides. Fine. Of course, you can take the CT slides also. But given the language of your question, so Dr. Devashish Man says, which one is better for small bowel diagnosis? So, Dr. Devashish Man says, which one is better for small bowel diagnosis? And the options he gave me are CT enterography, CT enterography, and the second is barium enema. Second option he gave is barium enema. You see here. Let's draw a large bowel. Fine. Now large bowel has to go like this. Fine. Now the small bowel is here. Now this point is ileocecal junction. This will act as a valve. Suppose you insert the contrast from here. It will take a long time to reach there. It won't be practically able to fill up the entire small intestine. So I believe CT enterography any day would be a better investigation. Dr. Umbir, no, it is not journey. It is not journey. Thank you, Gabru. Yes, this is an Army Navy retractor. So, Dr. Prem Patel, my friend Dr. Prem Patel, it's very nice to call the young fellows as your friends. थोड़े अपने आप की उम्र कम लगती है. He says, where do we need to put the needle in tension pneumothorax? In tension pneumothorax, you need to put the needle in second intercostal space, mid-clavicular line in children, fifth intercostal space, mid-axillary line in adults. Right? Very good. I mean, it's so good to see you that it's good to see that you guys know. Many of you know the answer. See, this is an Army Navy retractor. You can see there is a bigger prong on one side and there is a small prong on one side. So this for shallow dissection. This to be used for comparatively deeper dissection. Dr. Ariva Ramu, my friend Dr. Ariva Ramu, already, after the Family Man 2, we are already learning Tamil. After the Family Man season 2, we are already trying to learn Tamil. What is the difference between squamous cell carcinoma and adenocarcinoma? See, both of them, they are the tumors originating from epithelial cell line. Fine. But squamous cell carcinoma, adenocarcinoma is the carcinoma which is occurring from glands. Dr. Karthike Murugesh, see, CT scan for bony structure, CT scan for hard structure with different densities, CT scan for quick diagnosis. See, the word is densities. Fine. for quick diagnosis. For example, you use non-contrast CT scan in extradural hematoma. You use non-contrast CT scan in renal calculi, because there are different densities involved. Whenever you want to analyze soft tissue, whenever you want greater anatomical detail and time is not a concern, that means you want definitive but some kind of delayed results. If they are okay, then you can go in for MRI scan. Fine. MRI scan. Basal cell carcinoma is arising from epithelial tissue. Fine. Adenoma. See the word adenoma and adenocarcinoma. Common thing is that they both arise from glands. Adenoma, the word oma means it is a benign tumor. Adenocarcinoma means it is a malignant tumor. Malignant tumor arising from the glands. Dr. Aftar Ansari, there's a lot of difference between dumping syndrome and dumpling syndrome. Because of the lockdown, we have not gone to the markets, and I did not try my favorite dumplings. Fine. So dumplings are pakoras, all kind of pakoras, chicken pakoda and all. It's evening time, you should not be discussing dumpling. So you see, this is the normal physiology. Fine. Normal physiology, there is pyloric sphincter, which will stop the flow of food until it is digested to the point of being liquid. What surgery do we do? Let's say for acid, for cancer, suppose we perform this kind of surgery. Suppose we perform this kind of surgery like gastrojejunostomy. Fine. So you see, whatever food your patient eats will directly land up into the jejunum. Fine. Otherwise the transit of the food would be delayed like this. Now the food is entering directly. Fine. So in this case, what will happen is concentrated material is entering the jejunum. Fine. We have performed gastrojejunostomy. Fine. So what will it do? It will suck in all the water. And this will happen immediately, like within 15 to 20 minutes of your patient eating the food. Fine. So your patient will have hypovolemia, severe hypovolemia. That will give rise to early dumping. Now what will happen? Whatever food is digested, that will cause the dextrose level in the body to overshoot. When the dextrose level in the body overshoot, the level of insulin also overshoot. Fine. So what will happen? There will be fall in the level of dextrose. Fine. This will give rise to late dumping. But इसके लिए क्या चाहिए? For this we require digestion of the food. So this may take up to 2 or 3 hours. Dr. 192. See, ERCP. ERCP is endoscopic retrograde polycysto pancreaticography. Fine. So you see here what we do is, second part of the duodenum, we take our camera right up to the second part of the duodenum. We take our probe right up to the second part of the duodenum. Fine. And here what we can do is, we can inject a dye. We can inject a dye. Here, if there is a stone present, we can pick up that stone and remove it. Fine. So ERCP basically is invasive procedure. We are going very deep. We are doing endoscopy. Then we are reaching stomach. Then we are reaching intestine. And then we are injecting a dye. Then we are injecting a dye to see if any stone, if any mass, if any hematoma is present in the duct or not. Fine. Now, if any of these are present, for example, if stone is present, we can remove it. If any mass is present, we can take a biopsy. If any hematoma is present, we can safely remove it. Fine, we can safely remove it. If any bleeding is present, we can coagulate it. So basically, ERCP is both diagnostic as well as therapeutic. And you know, ERCP is considered the investigation of choice to confirm bile leaks, while the MRCP is just a diagnostic investigation. It will tell you about the bile ducts. Dr. Pranav Vyas, see, in my humble opinion, breast, sorry, I'm really sorry. In my humble opinion, you must know the breast cancer staging by heart. Then, if you can remember, you can renal cell cancer. Otherwise, I don't believe. I mean, in my humble opinion, these two are sufficient. Gastric outlet, Dr. Jyoti. What kind of open-ended question is this? Gastric outlet obstruction. Fine. It will cause to persistent vomiting. Fine. It will cause emaciation. Fine. Your patient will not be able to grow. It will cause severe anemia because the food will not be digested. Fine. Their iron will not be able to be digested. You know, the principal site of absorption of iron is duodenum. If the iron is not reaching the duodenum, it will not be absorbed. Your patient will suffer from iron deficiency anemia. Weight loss. Fine. Acid will be thrown out, so your patient may land up into metabolic alkalosis. Fine. Potassium will be lost out, so your patient may develop hypokalemia. These are all the symptoms. Tracheostomy is usually done on second, third, and fourth ring. No. I don't think pyrites is necessary. Only thing is, you should remember BIRADS. Fine. BIRADS is okay. So BIRADS, you know, 3. It is BIRADS 3. Teen tigada, kam bigada. Fine. So at 3, there are suspicious of malignancy. At 3, the suspicion of malignancy starts, though it is only 2%. Fine. It is only 2%. Fine. but the suspicion is still there. Suspicion is still there. Pirates. Pirates is not important. For quick blood transfusion, green or orange? See, I believe you are talking about massive transfusion protocol. I believe you are talking about massive transfusion protocol. When it is massive transfusion, when you are giving 10 unit at once, you don't use either of the cannula. You use a central venous catheter. Fine. 8 French central venous catheter. Fine. Now the indications. Suppose if you are doing it for trauma, 2 of the green catheters are to be used. 2 of the green catheters are to be used. So I believe going by the ATLS, the answer would be green catheter. Investigation of choice for acute and chronic pancreatitis both is contrast CT. Investigation of choice for both is contrast CT. Fine. If in a contrast CT you want to see ductal anatomy, in that case MRCP would be a better investigation, Fine. Now, see, the most common symptom in chronic pancreatitis would be pain. So if a patient comes to you with pain, first investigation would be contrast CT. Fine. Definitive investigation, again there would be MRCP. So on acute, if you want to find a one single answer, it would be contrast CT. For chronic, it would be MRCP. For chronic, it would be MRCP. Dr. Dhaval, I'll answer your query in a while. Dr. Mithila, most common cause of intussusception in children and adults. Fine. So in children, the most common lead point would be Meckel's diverticulum. In adults, it's usually going to be a polyp. Fine. So here it is ileocolic and here it is colocolic when we talk about the elderly adults. Most common, Dr. Paramjeet, it is spleen now. It is spleen. Most common is spleen. No, it is spleen. It is spleen. Spleen. Even I have a mnemonic to remember the cannula. Mnemonic to remember the cannula. So even I have a mnemonic. Let me just share the mnemonic with you. I think it's a picture. So the mnemonic, as you must have seen the picture. I'll share the picture on the group. It's like 24, 22, 20, fine, 18, 16, 14, fine. So orange, the earth core is orange, fine. Gray, the soil, fine. Green, The grass is green. Grass is green. Fine. And 20, pink. The flowers, they are pink. Blue, the sky. Fine. Yellow, the sun. Oh, it's got to be the sun. Sorry. It's got to be the sun. Fine. So this is the mnemonic available with me. But yes, our friend Dr. Schulz is also shared a good mnemonic. Fine. I believe spleen is the right answer. Spleen is the right answer. Fast. What is there in fast, bro? Fast. Focus assessment with sonography in trauma. So you see the four P's. Fine. Perihepatic. Perihepatic. Fine. What do you see here? The Morrison's pouch. Fine. Perisplanic. Pericardial. Pelvis. This is all you get to see. Four P's. Four P's. Fine. So if you get to see the seashore sign, that is normal. If you get to see the stratosphere sign, that indicates the presence of pneumothorax. This is when we talk about E fast. This is when we talk about E fast. Fine. E fast is when we look at the chest also. When we look at the chest also. Fine. So this has lower sensitivity. Fast has got comparatively lower sensitivity for retroperitoneal trauma. Retroperitoneal trauma. Fine. Lower sensitivity for penetrating trauma. Lower sensitivity for penetrating trauma. Penetrating trauma. Right. So lower sensitivity if there is less than 100 ml of free fluid. Less than 100 ml of free fluid. Gastric reconstruction, Bilroth one is simple. Let's say this is the stomach. Fine. So you remove this part and connect the rest. Let's say you connect A with B. That will be Bilroth one. Fine. And if you connect it like this, that will be Bilroth 2. That will be Bilroth 2. This is Bilroth 2. Dr. Arshad, staging, which staging? Dynamic and adynamic bowel obstruction. Let's say, sorry. Dynamic bowel obstruction when the bowel is trying to overcome. When the bowel is trying to overcome some resistance. For example, there is some obstruction and the bowel is desperately trying to overcome obstruction. That is dynamic. When the bowel is listless, It is not trying to overcome this obstruction. This is a dynamic. This is a dynamic obstruction. So varicose veins, if only calf pain is there, if only calf pain is there, you ask the patient to avoid prolonged standing. You ask the patient to avoid prolonged standing. You ask the patient to avoid strenuous walking. If patient has lipoderma sclerosis, if patient has lipoderma sclerosis, you ask the patient to wear compression stockings. Why? To give support, to give support to the veins. Fine. Next, if the patient has developed venous ulcer, if the patient has developed venous ulcer, fine, in that case the treatment is Bisgard regime. Bisgard regime. Compression stockings, fine. Limb elevation and massage fine. Now, if the patient has saphenofemoral junction incompetence, fine, the treatment is Trendelberg operation. Now that is an old concept, fine. New 27th edition of Love and Bailey clearly says that endogenous energy is the treatment of choice. Endogenous energy includes laser ablation. It also includes radio frequency ablation. Fine. So if they ask you one single treatment, the treatment of choice is laser ablation, fine, or radio frequency ablation. If you have to choose between one and two, you always go in for one, the endogenous venous laser. Endogenous venous laser, fine. For reticular veins, that means the small vein, the spider vein, fine, the treatment is sclerotherapy using foam prepared by Tessari technique, fine. So that was the treatment for varicose veins. Dr. Priyadarshini, yes, of course we can do flaps, but first let me take up all other questions. Of course, I'll show you all the flaps. Other dehiscence other than Killian, okay. Just give me a minute. What is there? Okay. See, these are the other dehiscence. So this muscle, as you can see, is thyropharyngeus, which is supplied by pharyngeal plexus. This muscle, as you can see, is cricopharyngeus, which is supplied by recurrent laryngeal nerve. So if the dehiscence is between these two muscles, this is going to be the Killian's triangle. If the dehiscence is between the cricopharyngeus and the other muscles of esophagus, this is going to be the limar diverticulum. limar diverticulum, limar diverticulum. Fine. If the dehiscence is right through and through the cricopharyngeus muscle, it is going to be the Killian Jamieson diverticulum. It is going to be the Killian Jamieson diverticulum. Let me show you. See here. The Killian Jamieson diverticulum. Fine. This is a Killian diverticulum. This is a Killian Jamieson diverticulum. This is occurring through the cricopharyngeus muscle. I'll show you another image. See here. I hope that makes the things clear. Fine. Dr. Karthikay, trauma, breast, thyroid, and GIT. Are we left with anything? Dr. Sujata Gautam. Where is this? What is there? So you see, just remember one thing. When we are talking about the hypovolemic shock, so the most common type of shock is hypovolemic. Most common cause of hypovolemic shock is hemorrhage. You must have studied the lawn tennis scoring system. The lawn tennis scoring system. It is 0, 15, 30, 40. Same is the scoring system in shock. When 0 to 15%, that is around 750 ml of blood is lost. Fine. There are no major changes. There are no major changes. Fine. The effects, they are similar to blood donation. Effects, they are similar to blood donation. Fine. Now, 15 to 30% blood loss. That means 750 ml to 1500 ml. Only thing which is worth remembering here, kidney will be the first organ to be affected. Kidney will be the first organ to be affected. Kidney will be the first organ to be affected. So, there will be decreased urine output. There will be decreased urine output that will be less than 30 ml per hour. Less than 30 ml per hour. Fine. Now, next is 30 to 40% blood loss. 30 to 40% blood loss. 1500 ml to 2000 ml. At this stage, the only thing worth remembering is that the pulse pressure decreases. But I'm sorry. I'm really sorry. I'm really sorry. The pulse pressure decreases in the 50 to 30%. Pulse pressure decreases. When it is 30 to 40%, at that time, the systolic blood pressure also decreases. Systolic blood pressure also decreases. Fine. And when it is more than 40% blood loss, that means more than 2000 ml blood loss. Fine. At that time, what will happen is patient will either go into lethargy. Patient will go into lethargy and there will be anuria. There will be anuria. So these are the symptoms of shock. See, for any kind of shock, the preferred fluid happens to be crystalloids. Preferred fluid happens to be crystalloids. Crystalloids, they happen to be the preferred fluid. You always have to use crystalloids. Fine. Which crystalloid is to be preferred? Which crystalloid is to be preferred? Fine. So for crystalloid, you prefer ringer lactate. Why not normal saline? Because it has got too much of sodium. Too much of sodium. Fine. So that will cause rapid increase in blood pressure, rapid increase in blood pressure. You don't want that. Why? Because let's say if earlier the bleeding was occurring like this, once you rapidly increase the blood pressure, the bleeding would go like this. That is why, according to new concept, there is a concept of hypotensive resuscitation. That means systolic blood pressure is usually kept less than 70 millimeter of mercury in penetrating trauma. And if brain injury is suspected, it should be more than 90 millimeter of mercury. 90 millimeter of mercury. So, best is you give your patient crystalloids, fine, plus you give clot stabilizers like injection tranexamic acid, fine. First you give 1 gram stat, then it is repeated after 8 hours. After 8 hours this is repeated. So this is what to be followed in trauma. This is what is to be followed in trauma. Okay. Investigation of choice for dysphagia lusoria. Angiography. CT angiography. CT angiography. CT angiography. Intermittent claudication. The word claudication means limp. Pain which develops in exercising muscles. Pain which develops in exercising muscles. Fine. So this is classically seen in Berger disease, classically seen in smokers, young males, 20 to 40 years, young male, 20 to 40 years. Fine. So this is not, this part is very important. This is not relieved by first keeping the part in dependent position. If you let the limb hang, rest pain will be relieved. Fine. Second, this is not relieved by sympathectomy. This is not relieved by sympathectomy. Why? Because blood supply to the muscles is not under control of autonomic nervous system. Blood supply is not under the control of autonomic nervous system. Green, green, green. For trauma, always use 2 of the green cannulas. Gray, green and all nothing. For trauma, always use 2 of the green cannulas. Gray cannulas may be required in obstetric practice, not here. Fine. Crush syndrome. Crush syndrome. Fine. Crush syndrome, the key word is rhabdomyolysis. Fine. Muscles are crushed. Myoglobin is released into circulation. Myoglobin is released into circulation. Potassium is released into circulation. So your patient will have hyperkalemia. Negatively charged myoglobin attracts positively charged calcium. So your patient has hypocalcemia. Myoglobin blocks the tubules. Fine. So renal failure. Acute renal failure. Compartment syndrome is common in compartment syndrome is common in forearms I'm sorry, I want to write quick. Compartment syndrome is common in forearm. Fine. If there is tight cast, lengthy bariatric surgery. Fine. So there are so many P's. First, there will be pain on passive stretching. Why? Due to increased pressure. Nerves will be compressed, so there will be paresthesia. Arteries will be compressed, so there will be pallor. Because the blood is not going, there will be poikilothermia. Fine. You can expect the paralysis of the limb, and last, pulselessness. So this is a very late sign, should not be relied upon. What is the preferred treatment? Preferred treatment is prevention. How prevent? Prevention by careful observation. By limb elevation. Removal of circumferential cast. Fine. For established cases, long linear fasciotomy for established cases. We still perform DPL, diagnostic peritoneal lavage, when ultrasound is not available. We have to perform diagnostic peritoneal lavage. Fast is the investigation of choice in blunt trauma abdomen if the patient is unstable. It is the first investigation in stable patient of blunt trauma abdomen. Investigation of choice for pancreatitis. You have told that lipase. See, first of all, this is wrong. Investigation of choice remains contrast CT, but lipase is more specific than amylase. Fine. Amylase level amylase level, they are raised in any GIT pathology, even in some pleural pathologies, even in salivary gland pathologies, while lipase levels they are raised in pancreatic pathology. So they are more specific, right? Now you see HIDA scan, why it is used in acute cholecystitis, why it is used in acute cholecystitis. So you see, let's say these are the bile ducts. From there, they will be joined by cystic duct. They will be joined by cystic duct. Fine. And then it becomes common bile duct. Then it becomes common bile duct. Fine. So this is going to enter into the duodenum. Now this sphincter is always closed. So when you give HIDA to your patient, it gets concentrated. It gets concentrated. When the sphincter is closed, so it goes into the gallbladder. It goes into the gallbladder. Fine, like this. It will fill up the entire gallbladder. Fine. But what happens in acute cholecystitis? What happens in acute cholecystitis is that the gallbladder is badly inflamed. The gallbladder is badly inflamed. See, the gallbladder will be badly inflamed. So, HIDA cannot enter, your contrast media cannot enter the gallbladder. So, this will show absent gallbladder. This will show absent gallbladder in case of acute cholecystitis. You got to be more specific when we talk about rule of two. Maybe you're talking about Meckel's diverticulum. Maybe you're talking about Meckel's diverticulum. So 2% prevalence. That means in a class of 100 students, two students will have Meckel's diverticulum. Two students will have Meckel's diverticulum. Second, half, no, half of the symptomatic patients are less than 2 years of age, children. Fine. Second, it has two types of mucosa, gastric and pancreatic. It may have two type of ectopic mucosa. So it is present 2 feet away from the ileocecal junction. 2 feet away from the ileocecal junction. Fine. So that is the rule of two. See, these are the broad topics. Like, I mean, at this point of time, suppose you want to understand the topic of hernia. Don't you think it's a bit too much? I mean, of course, I'm always there to tell you about it, but then, Now you see, this is the difference between direct and indirect hernia. Difference between direct and indirect hernia. So this will be lateral to the inferior epigastric artery. Direct will be medial. Fine. If you want this, see, this is the difference. This is the difference. I have summarized the difference. Maybe you would like to take a screenshot or a see. This is better. If you want to take a screenshot, this image is better. Just give me a minute. Oh God, you have written so much. Just give me a minute. Right? We have opened so many slides now. Let me close some of the slides. I missed on because I missed on certain questions. Just give me a minute. No, 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 no. You don't need to remember the flow rates of cannula. You don't need to remember the flow rate of cannula. The earliest complication of ileostomy is necrosis. Earliest complication is necrosis. Necrosis. Fine. Necrosis. So see this word quick sofa. Quick sofa. Quick sofa is sequential organ failure assessment. See, lots and lots of things have changed after sepsis 3.0 guidelines. After sepsis 3.0 guidelines, the word SIRS is out, no longer used. The word severe sepsis is out, no longer used. We are talking about the septic shock. We are talking about the septic shock. Now, this word quick sofa, we check the respiratory rate if it is more than or equal to 22. Fine. We check the systolic blood pressure if it is less than 100 millimeter of mercury. Fine. Then we check the altered mental status with the help of GCS. With the help of GCS. Fine. So this is quick sofa. This is quick sofa. रुको जरा सबर करो. Who's this Hindustani bhau, by the way? Dr. Wahab. Dr. Wahab, and the typical image of Hindustani bhau is there in my mind, like that. Bit of flap surgery, okay, will do. Will do, will do. Don't worry, don't worry, don't worry. Someone has asked me what is the GCS related to intubated patient. GCS related to intubated patient. Fine. Let me see. Get me a glass of water, please. Okay. What you can do is, we'll spend 3-4 minutes on this PPT. We'll spend 3-4 minutes on this PPT. This is important. When we want to cover all the aspects of trauma. Fine. So you see lemon. When you do the airway assessment, fine, you first look externally if there is any facial trauma, large incisor tooth, fine, then you evaluate. You need to have 3 distances. You need to know the 3 distances like this. The distance between the 2 incisor, the distance between the hyoid bone and the chin has to be at least 3 finger breadths. The thyroid to mouth distance, thyromental distance has to be at least 2 finger breadth. Malampatti score has to be 3 or more than 3. Fine. In that case, you see here, your intubation, airway management can be difficult. Fine. How do you manage the airway? How do you manage the airway? Look at this. He is trying to insert 3 fingers. Fine. Good airway. Fine. Hyomental distance more than 3 finger. Good airway. Thyromental distance more than 2 fingers. Good airway. Fine. See here. Right. So this is 332. 332, right? Hyomental distance. Thyromental distance, right? Malampatti score. So here it is easy, it is okay, difficult, very difficult, or next to impossible. Next to impossible. That is the Malampatti score. Canadian cervical spine rule. This will tell you whether you get the cervical spine X-ray done or not. You don't need to go into the details. You don't need to go into the detail. This will just tell you whether you want to get the cervical spine X-ray done or not. Fine. Whether good, actually I had kept some of the questions, but because you guys are asking questions already, so I don't think I need to. I mean, I will ask some questions. So you see, these are the details which you can skip. Fine. Next is your nexus criteria. So nexus criteria will also tell you whether you want cervical spine X-ray done or not. Fine. Now this image, Guddle airway, also called as oropharyngeal airway, different size. I don't think you need to remember the color. Oropharyngeal airway. This is how you insert an oropharyngeal airway. Now these are the different parts of endotracheal tube. Last year in the NEET MDS exam, the different parts were asked. The different parts were asked. Just have a look. It is easy to remember. Bevel, the hole from which the air will come. Murphy as an escape route. Cuff, so that the tube remains inside the trachea. Fine. Pilot balloon. To fill up this balloon, will inject air from here. Fine. Now this blue colored thing is an adapter. The radius is called Meckel curved radius. Meckel curved radius. Fine. The tube has a radio opaque marker. Fine. Radio opaque marker. Fine. Now this black color thing is the vocal cord guide. Very important. Vocal cord guide. If this passes, that means your tube is already past the vocal cords. Right? This is how you insert an endotracheal tube. Fine. Now this is orotracheal. Fine. So orotracheal intubation is contraindicated in mid-phase fracture. Fine. Nasal intubation is contraindicated in base of the skull fracture. Fine. So these are the different contraindications. Contraindications of endotracheal intubation. Salic maneuver. What is Salic maneuver? Pressure over the cricoid. That will make the trachea more prominent. That will compress the esophagus. Cricothyrotomy done with a 16 gauge needle can give the air for 15-20 minutes. Why not longer? Because then it will cause hypercarbia. Fine. So what we are studying is needle cricothyrotomy. Maximum for 15-20 minutes, not more than that. Fine. Surgical cricothyrotomy. We give an incision like this. Fine. We cut the cricothyroid membrane. So this is an emergency procedure. See, this membrane we are supposed to cut. Cricothyroid membrane. There was a question where to give the incision. Below the cricoid cartilage or above? So answer is above the cricoid cartilage. See, this is needle cricothyrotomy. So this is skin incision, which has to be vertical. After that, we can give horizontal incision like this. Needle cricothyrotomy. Again, this is called as London sign. London sign means, this I told in the last class also, London sign means patterned bruising. You see, here seatbelt injury is there. Fine. Seatbelt injury will increase the chance of rib fracture. Just a minute. So, even otherwise, the most common rib fracture are second to seventh. Most common rib fracture also second to seventh are most common. 90% of the ribs fracture are from second to seventh. And of these 2 to 7, 4 to 6 rib are more commonly fractured. Fine. So seatbelt injury can cause 4th to 7th rib fracture. Spine fracture would be chance fracture due to hyperflexion injury. Due to hyperflexion injury. Fine. This is how the spine fracture would occur. Again, this is London sign, patterned bruising. Log roll method not being done anymore, not recommended anymore. So minimum 4 persons, minimum 5% if there is limb fracture. Now this has been replaced by whole body CT scan. Whole body CT scan. Fine. The exposure is equal to 75 chest x-rays. Is equal to 75 chest x-rays. Fine. Yes, breast cancer, flaps is there on my mind. I'll do it with you. Fine. So, triage. Triage. So, in the triage, what you will do is that being the worst will make you the first. You try to attend all the patients in such a way that maximum possible number of lives can be saved. Maximum possible number of lives can be saved. So you give color coded bands to the patient. Color coded bands to the patient. Fine. See, trauma is important. So in trauma, red category patient, first of all, they are attended first. Priority in being shifted to hospital. Priority in being shifted to hospital. You see here how in the question, in the scenario based question, how will you be able to identify a red category patient? You see here, red category patient, they require immediate attention. So anyone who has got heart rate more than 120, respiratory rate more than 30, he is looking directly into the face of death. He is looking directly into the face of death. So you have to save this patient. You have to save this patient. So any patient with heart rate more than 120, respiratory rate more than 30 or less than 10. Fine. Patient who is unable to follow simple command, they must be attended immediately and they should be put in red category. Should be put in red category. Should be put in red category. This is extremely important. Fine. Now you see here what comes after red. After red comes the yellow category. Yellow category are the patient who need to be attended urgently. Urgently. And what is a typical example there? See, if the typical example in red is tension pneumothorax, in urgent it would be open pneumothorax. In urgent it would be open pneumothorax. Yellow category, urgent attention. The typical example, open pneumothorax and pelvic fracture. pelvic fracture. Why pelvic fracture is there in the list? Why pelvic? Jivesh bhaiya ko call kar le. Why pelvic fracture is there in the list? Because there could be venous bleeding, 2.5 to 3 liters of venous bleeding can be there. Fine, in the pelvic fracture. Fine, that is why it has to be attended. How do we manage? By pelvic binder or by selective embolization. Fine. ATLS 10th protocol clearly says no springing of pelvis, no springing of pelvis, no digital rectal examination, no digital rectal examination in the patients who have suspected pelvic fracture. हर चीज में उंगली करना अच्छी बात नहीं है. Fine. Now, delayed management, green tag. Typical example will be closed fracture. Closed fracture. Fine. Closed fracture. Now, very often, many of us may make a mistake between compound fracture and complicated fracture. Compound fracture is open fracture. When apart from bone, soft tissue and skin are injured. Complicated fracture is when apart from bone, brain, lungs, liver or any other organ is affected. So that means bone plus any other organ. Bone plus any other organ. Fine. So you must keep in mind this, because when I came to the closed fracture, I thought I should tell you about this one also. So blue patient, expectant. How to remember this? The patients who we expect that they will die soon, but we want to give them a dignified death. Black, moribund, already dead patient. Fine. Already dead patient. So this may be given to moribund patient. Black may be given to dead patient. Last lecture I told you white will be given to patient who don't need any kind of medical management. Don't need any kind of medical management. Fine. Okay. How else can you do the staging? How else can you do the staging? We can also do the staging based on revised trauma score. Revised trauma score. What all is included in revised trauma score? Systolic blood pressure, Glasgow coma scale, respiratory rate. Fine. So revised trauma score was given by champion. Minimum score, maximum score 0. Fine. So anyone who has got score of 12, anyone who has got score of 12 is given green tag, and we may call it delayed. 11 is given yellow tag, and we call it urgent. 3 to 10 red tag. Fine. And we call it immediate. Less than 3, of course, you have to give black tag. Fine. Now comes the GCS. Fine. GCS always has been your favorite topic. Fine. Now, the GCS. What kind of score is GCS? GCS, of course, is a physiological trauma score, physiological trauma score. Fine. Now, you see here. So there are 4 eye signs, 5 verbal signs, 6 motor signs, 6 motor signs. Now, if you clearly see in the 6 motor signs, this sign, abnormal flexion, this sign of abnormal flexion, this, you see, abnormal flexion, this was entered later. It was not a part of original GCS. It was not a part of original GCS. Fine. Now, if you compare them, this sign, abnormal flexion is similar to decorticate posturing. Fine. You see here, you don't get to see flexion over here. Fine. You don't get to see flexion over here. Normally your patient is lying supine like this. Fine. Now decerebrate. This is similar to abnormal extension. Fine. Abnormal extension. You see here, everywhere it is extension. Fine. Everywhere it is extension. Decerebrate. Fine. Decerebrate. Now, again, there are some changes there. So, minor injury is with GCS 15, especially if there is no loss of consciousness. Fine. Minor injury can be there with the GCS 15 also. Fine. Mild injury. Fine. It can be 13 to 14. Now, moderate and severe are the same. Fine. So this is used in children. Same eye signs, same motor signs, but different vocal sounds. Adelaide Coma scale. Now, the new variable, I mean, they are not new anymore. You have already read them. Fine, but let's quickly revise them. After that, I will discuss. After this, after we are done with the trauma, next in the list will be breast cancer staging. And after that, I will ask some of the questions. So these are next on the list. After, because we are about to finish the topic of trauma. Fine. After that, we'll discuss some of the questions. Then again, we'll come to the topic of trauma and your queries. Fine. Pupil reactivity score. If both pupil are unreactive, the score will be 2. If one pupil is unreactive, the score will be 1. If both pupil are normal, the score will be 0. Another score is GCSP score, that equals GCS score minus pupil reactivity score. The third score is GCSPA score. So this is simply GCSP score adjusted according to age. Fine. You see here. That is GCSPA score. This is how we calculate the GCSPA score. So that tells you about the average expected 6 monthly mortality. Only the GCSPA score can do it. Average expected 6 monthly mortality. Fine. Now this, if right and left motor score are different. For example, in right the motor score is 3 In left, the motor score is 5. We must always choose. We must always choose 5. We must always choose 5. Fine. The better rate must be chosen. The better rate must be chosen. Fine. Now, someone just asked me if the endotracheal tube is there. So now this new word, NT, not testable, not testable. This should be used. The VT is no longer used. ENT, VNT, MNT. I not testable if there is bandage. Motor not testable if there is splinting. Fine. Vocal not testable if there is endotracheal tube. Is not if there is endotracheal tube. Fine. So I believe we have had enough of trauma. So now we come to the next thing there which someone wanted to discuss there with us. That is the breast cancer staging. I'll answer your queries later. I mean, after this. Immediately after this breast cancer staging. Immediately after this breast cancer staging, we'll discuss your query related to. By the way, I hope you guys are aware about this. I hope you guys are aware about this. The FNAC staging. FNAC staging. Just a minute. Now see, this is the pure TNM staging. The pure TNM staging. Let's discuss this T staging first. Let's discuss the T staging first. Fine. See, the simple one, T staging. Fine. I'll write it down here so that we can quickly recognize it. Don't go too much into the details as of now. So, T1. T1 will be your tumor less than 2 centimeter in size. T2, 2 to 5 centimeter in size. T3, more than 5 centimeter in size. More than 5 centimeter in size. T4, A, B, C, D. T4A, when chest wall is involved, skin is involved. When both are involved, this is inflammatory breast carcinoma. Inflammatory breast carcinoma. Fine. Inflammatory breast carcinoma. This is the T staging. T staging. Fine. Don't go too much deep into the details as of now. Fine. Especially if you have not discussed it earlier, don't go into the further details of T. Only thing which you can remember is TIS is carcinoma in situ, and TISP is for the Paget disease. For the Paget disease. TISP is for Paget disease. Right? Before we can discuss the N staging, must keep in mind 2-3 facts. 80% of the lymphatic drainage is to axillary lymph nodes. Rest 20% is to internal mammary lymph nodes. Internal mammary lymph nodes. Now, axillary lymph nodes They are divided, given by the mnemonic Palak. Palak. Fine. Level 1. Fine. Level 2. Level 3. Fine. So level 1, you know, they are the lymph nodes which are below and lateral to pectoralis minor muscle. Fine. So they are anterior, posterior, also known as subscapular, anterior also known as pectoral, and lateral, APL. Fine. APL. So if they are involved, that indicates good prognosis. Good prognosis. Fine. Now, level 2 indicates central lymph nodes. That means behind pectoralis minor. If they are involved, that indicates poor prognosis. That indicates poor prognosis. Level 3, that is apical lymph nodes. If they are involved, that indicate worst prognosis. Fine. So they are called infraclavicular. They are also called Halsted lymph nodes. So ultimately, lymph from all of them goes to supraclavicular lymph nodes. Supraclavicular lymph nodes. Another thing, internal memory lymph node, if they are involved, that will be called as poor prognosis. That will be called as poor prognosis. Fine. So based on this information, I want you to spend 20-30 seconds on this. Meanwhile, I'll have a look at your queries. Look on your queries. Right? Okay. So we'll move forward. There are, sorry, the screen is shaking as always. No problem. See, N0, no nodes. Fine. When we talk about N1, N2, N3, fine. We say good nodes. I mean, there's nothing good in nodes. Fine. But good nodes still manageable. Still manageable nodes. Still manageable. Difficult to manage. Difficult to manage. So what all is included? What all is included in good node? Ipsilateral, that means on the same side. Mobile, discrete, axillary nodes. Mobile, discrete, axillary nodes. Fine. Now, if you want to remember this, N1, this is N1A, this is N1B, internal memory nodes, but discovered on Discovered on sentinel lymph node biopsy. Discovered on sentinel lymph node biopsy. See here, they are discovered clinically. They are discovered clinically. Here, they are not discovered clinically. Not discovered clinically. N1C, N1C, internal memory plus axillary. They are both discovered on sentinel lymph node biopsy. That means clinically they are not apparent. Clinically they are not apparent, but they are discovered, fine, on lymph node biopsy, sentinel lymph node biopsy. Now same, if you want to remember the N2B in N2B, internal memory lymph node will be clinically apparent. Compare both of them. Compare both of them. In N1B, internal memory lymph nodes are present, but they are not apparent clinically. Here in N2B, they will be apparent clinically. What is N2A? N2A again you have to compare. N2A you again have to compare. Here they are mobile, but in the N2A they will be fixed. They will be fixed. Fixed axillary. That is the difference from N1 to N2. N1 to N2. They will be fixed to themselves or to other structure or to other structure. See, N3, difficult. If we talk in common language, gone case. If we talk in common language, gone case. A, B, C. Simple thing to remember. Simple thing to remember. Infraclavicular, supraclavicular, infraclavicular, supraclavicular. Fine. 3A, 3C. Fine. Here, internal memory plus axillary, internal memory plus axillary, and both of them are clinically apparent. Both of them are clinically apparent. Let's see if you can digest this fact or not. Let's see if you can digest this fact or not. See, only thing is, if you can remember these two shift, if you can remember these two shift, it will become very easy. Remember these two shift which I have marked with yellow. Another thing which you can remember is infra and supra. Fine. So these lymph nodes still manageable. They can be easily managed and difficult to manage. Difficult to manage. M staging, you know, is very simple. M staging. M0 metastasis present. Metastasis not present. M1 distant metastasis present. That is simple. That is simple. Fine. So with the lymph nodes we move forward. Now you have to remember this. Now you just have to remember N1 easily managed, N2 difficult, N3 gone case. Fine. We talk about the staging. We talk about the staging. So first, stage 1, stage 2. They are called early breast carcinoma. When we say early breast carcinoma, breast conservation surgery is still possible. Stage 3, locally advanced breast carcinoma. Locally advanced breast carcinoma. treatment is modified radical mastectomy. Modified radical mastectomy. Stage 4, of course, is metastatic carcinoma. Metastatic carcinoma. So, stage 1, tumor is limited to breast. Stage 1, tumor is limited to breast. No lymph nodes. No lymph nodes. Fine. So, stage 1 will include T1 tumor. When I write T1, that means everything else is not there. When I write just T1, that means everything else is not there. Stage 2. So the disease is either limited to breast or has manageable lymph nodes or has manageable lymph nodes. Manageable lymph nodes. Now you see what is there. This will include T2. I told you no lymph nodes. This will include T0, T1 plus N1. Fine. So T2, you see the disease is still there in the breast. Still there in the breast. Or N1, that means has manageable lymph nodes. Has manageable lymph node. This is our stage 2. This is our stage 2. Fine. Stage 2. Stage 2. Stage 2 will also include T2 plus N1. T2 plus N1. Fine. Stage 2 tumor plus still manageable lymph nodes. Still manageable lymph nodes. T3, again you see the disease is still limited to breast. Is still limited to breast. Still limited to breast. Fine. So we can call this stage A. We can call this stage B. 2A or 2B. Fine. Have a look here because this is the stage which causes confusion. This is the stage which causes confusion. Let's quickly summarize it. Disease which is limited to breast. And you see here the disease is limited to breast. Disease is limited to breast. No lymph nodes. Of course, it is T2, it will be A. It is T3, it will be B. Fine. Manageable lymph nodes. Manageable lymph nodes. Fine. So T1, it will be lighter disease A. T2, it will be heavier disease, stronger disease, more problematic disease. So T2B. If manageable lymph nodes are present. Manageable lymph nodes are present. Fine. If you want to summarize the stage 3 is the disease of bad lymph nodes, is the stage of bad lymph nodes. Bad lymph nodes. Fine. So T0, T1, T2, T0, T1, T2 plus N2, bad lymph node. T3, T3 plus N1, T3 plus N2. So this is big tumor. So this is big tumor plus bad lymph nodes. Big tumor plus bad lymph nodes. Big tumor plus bad lymph nodes. So let's call this A. Let's call this B. B. 3B is the stage of inflammatory. Is the stage of inflammatory breast carcinoma. Inflammatory breast carcinoma. So it should be T4. T4. Fine. T4 plus N0, N1, N2. We know, why do we say the stage of lymph nodes? Because we know 75% of the inflammatory breast carcinoma have lymph nodes at the time of presentation. At the time of presentation. 3C. 3C. Now, this is the disease of N3, the worst lymph nodes. Fine. NET plus N3. This is the disease stage of worst lymph nodes. Worst lymph nodes. Have a quick look. Have a quick look about the 3A. Just enlarge it. I told you the bad lymph nodes. Bad lymph nodes. Where are the bad lymph nodes? N2. N2. Fine. N2. Okay. N3. The worst lymph nodes. Right. Okay. So wherever you get to see N2 lymph nodes, see N2 lymph nodes are not there in the stage 2. They are only present in the stage 3. They are only present in the stage 3. Right? They are only present in the stage 3. Okay. While T staging can be there. See, this stage 3 has got T1, T2, and T3. Fine. Everything is there. Even T4 also. T staging is there everywhere. Fine. Only N staging you have to differ. N staging. For N staging you have to differ. Fine. When we talk about M0, no metastasis. M1. M1 means distant metastasis, and you know it. Presence of contralateral axillary lymph node in the absence of a tumor in contralateral breast is also considered metastatic carcinoma. Is also considered metastatic carcinoma. Is also considered metastatic carcinoma. Right? Is also considered metastatic carcinoma. So I believe this was your staging. Right? This much staging, if you can remember, I believe it's okay. I believe it's okay. Fine. Right. See here. We can come to the breast, but then let's discuss some of the questions. Let's discuss some of the questions, and let me take your queries first. As promised, I'll take your queries. You know, trauma and breast, they're always time consuming, they're always important. रुको जरा सबर करो. Difference between arterial and venous ulcer. Arterial and venous ulcer. Arterial ulcer, punched out edge. Fine. Sloping edge. Arterial ulcer, excruciatingly painful. Excruciatingly painful. May be painful, plus they are itchy. Plus they are itchy. Most common location is extremities. Most common location is gator zone. Gator zone, that means near the medial malleolus, near the medial malleolus. Fine. Okay. So the Parkland formula, fluid formula earlier was 4 ml per kg body weight per unit body surface area burned. Now it is modified like this: 2 ml per kg per unit body surface area for partial thickness burns in adults, 3 ml per kg per unit body surface area for partial thickness burns in children. Less than 30 kg, you have to add dextrose as maintenance fluid. 4 ml per kg per unit body surface area for deep, that means full thickness, that means third degree, and electric burns for both adults as well as for children. These are the modification. Urine output in adults, minimum 0.5 ml per kg per hour. Urine output in children, minimum 1 to 2 ml per kg per hour. Urine output in electric burns, 1.5 ml per kg per hour. Fine. Collar stud abscess. Let's say this is the skin. Let's say this is the deep fascia. This is collar stud abscess. Collar stud abscess is dumbbell shaped abscess, typically seen in tuberculosis. When you press from here, the swelling will come here. Fine. When you press the deep part, the swelling will go superficial like this. So it can move from region 1 and region 2. Dumbbell shaped abscess. This is your collar stud abscess. Collar stud abscess. Just a minute. Somebody of you wants to know the points related to radical neck dissection. Good question, because lot has changed. Lot has changed in the radical neck dissection. Lot has changed in the radical neck dissection. Fine. So in the radical neck dissection, you see here, cervical neck dissection. Cervical neck dissection. First of all, what is level 6? The central lymph nodes. The central lymph nodes. Level 5 lymph node are seen in posterior triangle. Posterior triangle. Fine. I'll show you the image. Don't worry. Level 2, 3, 4. Fine. Upper, middle, and lower jugular. Fine. Level 1, submental, submental, submandibular. Fine. Let me show you. See, these are the lymph node levels. Lymph node levels. Fine. So 6 central. Fine. Along the sternocleidomastoid muscle or along the jugular vein. 2, 3, 4, upper, middle, and lower. Fifth are those which are seen in the posterior triangle. Posterior triangle. Then there are level 7 lymph nodes. Level 7 lymph nodes, they are mediastinal lymph nodes. Mediastinal lymph nodes. Fine. Now, the different surgeries. When you do the dissection of level 6 lymph nodes, that is known as central lymph node dissection. That is known as central lymph node dissection. Central lymph node dissection. Fine. Central lymph node dissection. Now, there is radical lymph node dissection. Radical lymph node dissection when we perform removal of level 1 to level 5 lymph nodes plus 3 extra lymphatic or non-lymphatic, if you want to call it, extra lymphatic or non-lymphatic structures like sternocleidomastoid muscle, internal jugular vein, spinal accessory nerve, spinal accessory nerve. Fine. Then there is modified radical lymph node dissection. Modified radical lymph node dissection. So you see 1, 2, 3. Fine. So this is of 3 types. Fine. In modified radical neck dissection type A, we save one extra lymphatic structure. 2, all the 3 extra lymphatic structures, all the 3 extra lymphatic structure, they are saved. All the 3 extra lymphatic structure, they are saved. Fine. Now when we save all the 3, if we save all 3 extra lymphatic structures, we may also call it functional neck dissection. We may also call it functional neck dissection. Functional neck dissection. Now, supraomohyoid neck dissection. Supraomohyoid neck dissection. We remove level 1 to level 3 lymph node. Then there is extended supraomohyoid neck dissection. We remove level 1 to level 4 lymph node. We remove level 1 to level 4 lymph nodes. Right? Okay. Name of the incision used is Cocker by incision or trial incision. Trial incision. Right? Ecclesia cardia investigation of choice, barium swallow. Heart sounds in medicine. No, I cannot do that. I don't know the ABC of medicine, to be honest. Cardiac output. If you want to remember just the basics, cardiac output will be decreased in hypovolemic shock, will be decreased in cardiogenic shock. You know, heart fails as a pump, heart fails as a pump, will be increased in form stage of septicemic shock. Septicemic shock. Fine. May be normal or decreased in neurogenic shock. More chances of it getting decreased. More chances of it getting decreased is normal in dissociative shock. What is dissociative shock? When patient has carbon monoxide or meth hemoglobinemia, everything is normal. Everything is normal. Only thing is that the hemoglobin is not carrying oxygen. Hemoglobin is not carrying oxygen. Fine. It is generally decreased in anaphylactic shock. Anaphylactic shock. Generally decreased in obstructive shock. If you don't want to remember too much, remember first point, second point, fine, and third point. This is the barest minimum you should remember. And if you have got some kind of analytic mind, you will be able to know the reason why it is decreased. Fine. If you want to remember the rest, you need to have some deeper insight. Some deeper insight. Esophagus manometry, Dr. Sahib Pathan. Dr. Sahib Pathan. Esophagus manometry, if you want to do the esophagus manometry, the results, they are unpredictable. Because of food, too much food, sometimes the esophagus pressure will be high. If the food is not there, the pressure will be low. Fine. So this we don't use. That is why we prefer the barium swallow. That is why we prefer the barium swallow. Okay, let me ask some of the questions now. If I'm missing anything, do let me know. This is a difficult question. Let's leave this. Yes. Tell me the answer to this question. Read it and tell me the answer to this question. How can I just enlarge it for you? Please read this question. Now you see here. What I'm trying to ask you over here is, first of all, he is a young fellow. Fine. Job site as the base of ladder. Chad wound in. Oh, just a minute. This is malfunctioning now. So he has got some electric malfunction. We are discussing the electric burns, and by chance, I had removed my slippers and my feet was touching the ground actually, the iron ladder. So that is why this pen malfunctioned. So he has charred wounds in the left temporal region. Left arm is waxy, fixed inflection, fixed inflection. That means the muscle is already dead. Full thickness burn on his left flank and lower part of left leg is firm. Fine. Toes of his left foot are burnt and missing. Which of the following is the correct statement regarding electric injury? The cause of dark reddish urine, fine, will be revealed by urine examination and not CT scan. Will be revealed by urine examination. So this is wrong. Signs concerning for compartment syndrome should prompt urgent eschorotomy. What sign do you get to see over here? Already there is electrical injury. Fine. Early facial decompression of the extremities may be important in preserving limb function. You have to perform eschorotomy quickly. Whatever little blood flow is there, you have to preserve that blood flow. Now, this we have read that urine output should be minimum 1.5 ml per kg and not less than that. Again, that was a difficult question. Let's move to the next easy question. Let's move to the next easy question. If you know this topic, if you know the pharmacology, this is easy. If you know the pharmacology, this is easy. If you know the pharmacology, this is easy. So this question is out about priapism. This question is about priapism. Fine. Now, so your patient is suffering from low flow priapism. If there is priapism, you can do this. You can do this. Fine. This you cannot do. Why? Because papaverine is used to induce erection. It is used to induce erection. Fine. Now this is a preferred surgical treatment. This is a preferred surgical treatment. Fine. We are trying to do shunting. We are trying to do shunting of the blood. Fine. We are trying to do shunting of the blood. Exchange transfusion. If, for example, your patient has sickle cell anemia, we perform exchange transfusion. I believe again this was a difficult question. Right? Now, that's an easy one. Cameroon ulcer develop in which part of the ulcer? So they develop here. Cameroon ulcer. They are long linear ulcer. Long linear ulcer which develop in the herniated stomach. Which develop in the herniated stomach when your patient has hiatus hernia. When your patient has hiatus hernia. When your patient has hiatus hernia. So most common type of hiatus hernia is type 1. Fine. Most common type associated with complication is type 4. Type 4. Fine. Most common type associated with cardiac arrhythmia, it is type 3. So type 3 is common in elderly. Type 3 is common in elderly. Type 3 is common in elderly. Fine. So type 1 is sliding. Type 3 is rolling. Fine. Yes. Someone of you just wanted to ask about hernias. I'll just tell about hernias right now. Which of the following statement about management of inguinal hernia in infant and children is true? Hernia should never be delayed. It should be operated as early as possible. Fine. So this is definitely wrong. Hernia in children is an emergency. Bassini procedure is a type of herniorrhaphy. Is a type of herniorrhaphy. It is done in adults. So this is also wrong. Distal sac should be removed to prevent. Distal sac is not touched, is not even touched. Fine. Contralateral. This is the answer. This is the answer. Now, hernia. Hernia. Just a minute. Is the PPT open? Yes, the PPT is still open. Fine. You see here. Indirect hernia is common in young people. Direct hernia is common in aged people. Indirect hernia will pass through deep inguinal ring, then it will go to inguinal canal, then it will go to superficial inguinal ring. Direct hernia will travel through Hazelback triangle, then it will go to superficial inguinal ring. Indirect hernia is shaped like this. Direct hernia is shaped like this. Fine. Direct hernia is shaped like this. Fine. Inferior epigastric artery. Indirect hernia will be lateral. Fine. While the direct hernia will be medial. Fine. That is indirect and direct hernia. Now, what is the treatment? Treatment in children is herniotomy. That means we just remove the hernial sac. We push the content back into abdomen. Fine. Treatment in adults is herniorrhaphy. That is called primary tissue repair. Fine. No mesh is used. Shouldest, double breasting of transversalis fascia. Fine. Bassini. Fine. So we join the conjoint tendon to inguinal ligament. Fine. Now this is preferred surgery in strangulated hernia. Preferred surgery in strangulated hernia, hernioplasty, hernioplasty, we do herniorrhaphy, fine, sorry, I'm really sorry, I'm really sorry, we do herniotomy plus place a mesh, fine. So this is known as Lichtenstein repair, Lichtenstein repair. We can also do laparoscopic hernioplasty. When we do laparoscopic hernioplasty, we can treat direct inguinal hernia, indirect inguinal hernia. We can also treat femoral hernia. We can also treat femoral hernia. What are, when to do laparoscopic? First, if there is bilateral hernia. Fine. Second, if there is previously operated hernia, if there is previously operated hernia, fine, previously operated hernia, fine, if there is presence of other hernias also, like inguinal hernia plus femoral hernia, you need to remember the important landmarks, fine, like this. So this is abdominal wall, this is peritoneum, this is midline, fine, this is midline. Let's call this space 1, let's call this space 2. So space 1 is the space of Retzius. Space 2 is the space of Bogros. So both of them, they are called pre-peritoneal space. Pre-peritoneal space. Right? See. So you see, Retzius space, Bogros space. Fine. Now, you need to be aware about two things. So, this is the midline. You need to be aware about triangle of doom. If your instrument touches this area, fine, then iliac vessels would be injured. Patient will die. If your instrument touch the lateral area, there are too many nerves here. Right? Both of, see, this is medial, this is lateral. When we join, what do they form? The rectangle of disaster. Find rectangle of disaster. These are the two methods, TEP and TAPP. Don't go into the details. Fine. Fascia transversalis. Deep inguinal ring is a defect in the fascia transversalis. It is combined made by transverse abdominis and internal oblique. Yes, please answer this question. Direct inguinal hernias The truth is they are never congenital, and they are found in elderly patient. The risk is low. So this is wrong, this is wrong, this is also wrong, this is also wrong because it passes through the superficial inguinal ring. An indirect inguinal hernia, for example, pantaloon hernia. Pantaloon hernia has both direct as well as indirect. That direct as well as indirect. Synthetic mesh can be used for only for clean cases. Only for clean cases. Fine. See here what are clean and what are clean contaminated cases. So class 1 surgical wound, no exposure to mucosa. For example, hernia surgery. So no antibiotics may be used. 1D, when mesh or prosthesis is placed, antibiotics are used. Antibiotics are used. 2. I am trying to tell you in simple languages. Wound theoretically comes in contact with mucosa which is not inflamed. Which is not inflamed. For example, interval cholecystectomy. There is no infection, no inflammation. Fine. For example, interval appendicectomy. Interval appendicectomy. You know, this is done 6 weeks. This is done 6 to 8 weeks after acute appendicitis. Fine. Now, some of you might want to differ from me over here. So, type 3, when the wound touches non-suppurative infection, fine, that includes the appendicectomy in case of acute appendicitis. In case of acute appendicitis, fine. Type 4 are dirty infected wounds. Dirty infected wounds. That means where pus is already present, or suppurative, that means pus about to be formed, is already present. For example, abscess. For example, biopsy. Now, you see here, synthetic meshes can only be used for clean cases. If it is contaminated, we have to use biological mesh in hernia. Biological mesh is made up of collagen or dermis. Yes, Dr. Nishant, you're right. Fine. Sorry. For clean contaminated also. Fine. If it is contaminated, we don't use any mesh. Fine. So I'll write it in front of you. So in clean we can use synthetic mesh, contaminated, no mesh. After you control the infection, biological mesh. Clean contaminated cases, biological mesh. Clean contaminated cases, biological mesh. Right? Dirty wound, no mesh at all. No mesh at all. Fine. Biological mesh only after control of infection. Fine. Ischemic orchitis. Dr. Kalpu, pyoderma gangrenosum is a skin condition which develops if your patient has collagen vascular diseases like rheumatoid arthritis, like SLE, those sort of things. Pyoderma gangrenosum. Fine, that's a skin condition. Yes, ischemic orchitis manifests within 2-3 days. So this is a condition which develops during hernia surgery. Why? Due to thrombosis. Due to thrombosis of genital veins. Due to thrombosis of genital veins. So this will manifest within 2 to 3 days. Dr. Jyoti, Jabardast sarcasm on my handwriting. Next time I'll definitely try to improve my handwriting. I'm really sorry. I'm really sorry about my handwriting. I'm really sorry. Really sorry about my handwriting. So you have any other queries or shall I continue with the questions? Okay, answer this question please. I'm sincerely regretful about my handwriting. I'm really sorry. I'm really sorry. I'll try to improve my handwriting. So whenever you see this word posterior pharyngeal neck mass, whenever you see this word posterior pharyngeal neck mass, fine, always think about one thing. What? Always think about lingual thyroid. Always think about lingual thyroid. This is the answer. This is the answer. Fine. So, lingual thyroid. Lingual thyroid is a mass which moves with protrusion of tongue but does not move with deglutition. Does not move with deglutition. Fine. Now, the investigation are radioactive iodine scan, which is done with iodine 123. Which is done with iodine 123. Iodine 123. Why? Because it has a very short half-life of 11 to 12 hours. Very short half-life of 11 to 12 hours. Fine. You can also do ultrasound, which will show absent absent thyroid gland in the neck. Absent thyroid gland in the neck. Fine. Most common clinical feature is hypothyroidism. Treatment is surgical removal. Complication is follicular carcinoma. Complication is follicular carcinoma. Okay, now answer this. See, thyroglossal cyst is a midline swelling present slightly towards the left. Fine. Now you see midline swelling, collar stud, midline swelling, dermoid cyst, midline swelling. Only this swelling is present away from midline. Why it is present away from midline? Because lateral aberrant thyroid is just a metastatic lymph node, is just a metastatic lymph node. Yes, answer this question please, anyone. This is a simple one. This is a simple one. Can you please try to answer this question? See, if going by the earlier pattern, what is the question asked here? What is the question asked here? Fine. The question asked is, what is the first investigation in case of solitary thyroid nodule? In case of solitary thyroid nodule, what is the first investigation? What is the first investigation? Fine. So answer here is thyroid function test. Thyroid function test. Fine. If they ask you what is the investigation of choice, what is the investigation of choice, that has to be fine needle aspiration cytology. That has to be fine needle aspiration cytology. Now let's see if any one of you wants to differ. If any one of you wants to differ here, fine. What is the investigation of choice in solitary thyroid nodule? It is FNAC. What is the investigation of choice if your patient has dysphagia, any kind of dysphagia? Fine. First investigation here would be barium scan. Why barium scan? Because we want to exclude Zenker's diverticulum. Then after we will do endoscopy. Fine. Investigation of choice for gallbladder stone. It has to be ultrasound. Fine. Investigation of choice for acute cholecystitis. Fine. It has to be ultrasound. Confirmatory investigation is HIDA scan. Confirmatory investigation is HIDA scan. Investigation of choice for salivary calculi. It has to be non-contrast CT. Fine. Investigation of choice for renal calculi. Again is non-contrast CT. For acute pancreatitis, it has to be contrast enhanced CT scan. Contrast enhanced CT scan. Post-operative biliary leak, ERCP. Post-operative biliary stricture, it has to be MRCP. Post-operative biliary stricture, it has to be MRCP. Intestinal obstruction, it has to be contrast CT. Solitary rectal ulcer, it has to be sigmoidoscopy. Fine. Sigmoidoscopy. For breast carcinoma, it has to be true cut biopsy. It has to be true cut biopsy. Fine. For Paget disease, punch biopsy. For bladder carcinoma, endoscopic biopsy. Fine. For renal cell carcinoma, it has to be contrast CT. For renal cell carcinoma with vascular invasion, it has to be MRI. For prostate, it has to be transrectal ultrasound guided biopsy. Gastrointestinal stromal tumor, contrast CT. Mind you, in gastrointestinal stromal tumor, endoscopy is not helpful because the tumor is deep seated. For recurrent gastrointestinal stromal tumor, the investigation of choice is PET CT. For cholangiocarcinoma, investigation of choice is MRI with MRCP. Fine. For blunt trauma abdomen patient which is unstable, investigation of choice is fast. Stable, investigation of choice is contrast CT. Fine. I told you earlier also that the first investigation there is always fast. For Berger disease, the investigation of choice is angiography. For AV fistula, investigation of choice is MR, magnetic resonance angiography. Fine. For aortic dissection, the investigation of choice is CT based angiography. Aortic dissection patient, if unstable, the investigation of choice will be echocardiography. Remember, will be echocardiography. Investigation of choice for deep vein thrombosis will be duplex scan, which is a type of ultrasound. Investigation of choice for posterior urethral valves will be MCU. Micturition, cystourethography. So what it will show? It will show vesicoureteric reflux. It will show cricket ball bladder. It will show cricket ball bladder. Investigation of choice for urethral injury. It will be retrograde urethrogram. It will be retrograde urethrogram. For bladder injury, cystogram. For bladder injury, cystogram. Renal tuberculosis, contrast CT. Head injury, non-contrast CT. Head injury which has got diffuse axonal injury, MRI, only MRI. Someone of you asked me what is the investigation of choice for dysphagia lusoria. I told you at that time also, it is CT angiography. It is CT angiography. Gastric antral vascular ectasia. Fine. The watermelon stomach. So it got to be endoscopy. Diverticulosis. Barium enema with air contrast. Diverticulitis CT scan. Fine. Ectopic parathyroid. So we do SPECT scan with sestamibi. Fine, with sestamibi. Fine. Now you see, what I commonly observe is that many of you may make, I'm not saying that you will make mistake, but at some point of time, you may make mistake. For example, they may ask you most significant prognostic markers in cancers. See, only when we talk about Wilms tumor, only when we talk about Wilms tumor, the grade of tumor is the most important marker. Fine. Also in the sarcoma, the grade of tumor is the most important marker. Fine. But For all other cases, fine, for all other cases, please don't make this mistake. Overall stage is considered most important prognostic marker. If overall staging is given in the options, please do consider marking that. I know what you have read is that in esophagus, T stage is most important prognostic marker. Fine. This is also the most important prognostic marker in stomach cancer. Most important prognostic marker in stomach. For example, axillary lymph node status is the most important prognostic marker in breast cancer. Fine. In the breast cancer. Fine. If breast cancer is metastatic, ERPR status is the most important prognostic marker. So gist of the matter is overall staging is given. Do consider that. Fine, do consider that. Very good. Okay. So if you have any queries, do ask me. Otherwise, I'll keep on asking some questions. Don't go anywhere. Answer this question. Dr. Shalini, Dr. Gento Thomas, don't go anywhere. Answer this question. Yes, this is the answer. This, of course, you will operate. Non-compliance will operate. There is risk of cancer. Fine. So you will operate. Severe graves of ophthalmopathy will improve after surgery. So you will operate. Okay, tell me, what is this which developed after 7 years of mastectomy? Which developed 7 years after modified radical mastectomy? No, this is not lymphedema. Dr. Prem Patel is close. C. So the different type of mastectomy, Patte's mastectomy, we remove level 1, level 2, level 3 lymph nodes. Pectoralis minor is cut, is excised, is removed. Scanlon, we remove level 1, level 2, level 3. Fine. Pectoralis minor is just divided, is just incised. Fine. Auchincloss, most commonly performed, we remove level 1, level 2. Pectoralis minor is just retracted, So this complication is lymphangiosarcoma, which is known as Stewart-Treves syndrome. Treves syndrome. Fine. So typically it develops 5 to 10 years after mastectomy. Fine. So it will be in the clinical question, it will be in the form of raised brown nodules. That will be the language of question. Developed 3 years after mastectomy. What is this? It developed 3 years after mastectomy. What is this? Have you heard? I mean, of course, you have heard about cancer and cuirass. So this is cancer and cuirass. Cancer and cuirass. Skin studded with metastatic deposits. Skin studded with metastatic deposits. Yeah, that's a simple one. That's an easy one. What is this? That's a simple one. That's an easy one. What is this? Stewart-Treves, the syndrome is amputation. 4/4 amputation. You just have to cut it. No other choice. What is this? This is flame sign. Flame sign which is seen in extra peritoneal bladder rupture. Extra peritoneal bladder rupture. What is this? Carrel's anastomosis. So which layer suturing is must? Tunica media. Tunica media. Carrel anastomosis for arteries and veins. Okay, so you want to know how to appreciate fracture. First of all, you should be aware about the knot. Square knot, one throw, second throw, both below the first throw. Fine. Granny knot, one throw, second throw, one above, two below. Surgeon knot, two knots followed by one securing knot. Aberdeen knot, also called as cobbler knot. Surgeon knot, two knots followed by one knot. Square knot, one knot followed by one knot. Fine. So square knot is secure knot. Granny knot, one knot followed by opposing second knot. So this is unsecure knot. Half hitch ligating knot. Ligating knot. So this first, second, third, fourth, they are all in one straight line. So this is vertical mattress. This is used for eversion of the tissue. Used for eversion of tissue. First, second, third, fourth. So they are in two lines. So this is horizontal mattress. Horizontal mattress. See, this is chiral anastomosis for blood vessels. The different number of blades. Granny slip. Yes, granny can slip. All well. Okay, someone of you has asked how to appreciate fracture. Someone of you has asked how to appreciate fracture. See, for fracture, the sign, two signs are there. The sign which is considered most pathognomic, that is abnormal mobility. Abnormal mobility. Fine. Second is like if you get to see bony crepitus, that is the second most pathognomic sign. For stress fracture, point tenderness, fine. Point tenderness is the most pathognomic sign, fine. Okay, now very quickly a small list. Very quickly a small list. Fine. So most common symptoms in carcinoma esophagus. In carcinoma esophagus, it will be dysphagia followed by weight loss. Weight loss. In carcinoma stomach, it will be abdominal pain followed by weight loss. In periampullary carcinoma, it would be jaundice. In hepatocellular carcinoma, it would be pain followed by weight loss. Fine. In cholangiocarcinoma, painless jaundice. Fine. In carcinoma gallbladder, pain. Fine. Colicky, pain. In carcinoma of the small bowel, pain. In carcinoma rectum, bleeding per rectum. Fine. In anal canal, carcinoma, most common clinical feature is bleeding per rectum. Fine. Bleeding per rectum. So many most commons there. Last list. Promise. Last list. Most common site of gastric outlet obstruction is first part of duodenum. Is near the first part of duodenum. Most common site of small bowel adenocarcinoma. This has to be duodenum. Most common site of small bowel atresia. This also has to be duodenum. Fine. Crohn's disease. Terminal ileum. Terminal ileum is also the most common site for typhoid. tubercular ulcer, and small intestine lymphoma. Small intestine lymphoma. Small intestine lymphoma. Most common site of esophageal carcinoma is middle. Dr. Jyoti, it is middle. It is middle. Never make this mistake. It is always middle. And it is always squamous cell as of now. Fine. Middle one third. Middle one third. Fine. It is also the most common site for gallstone ileus. Most common site for amoebic colitis is cecum and ascending colon. Cecum and ascending colon. Fine. Most common site for ischemic colitis is splenic flexure. Splenic flexure. Ischemic stricture. Ischemic stricture. It is sigmoid colon. It is sigmoid colon. Most common site for valvulus is sigmoid colon. Is sigmoid colon. Fine. Most common site for ulcerative colitis got to be the rectum. Got to be the rectum. CA colon. CA colon. Fine. Again, it's got to be the sigmoid. Least common for CA colon, it has to be hepatic flexion. It has to be hepatic flexion. Hirschsprung disease, it has to be rectum. It has to be rectum. Fine. Again, so many things to be discussed. So many things to be discussed with you. But the paucity of time, again your patience, again your strength, again your energy, everyone tends to get tired at times. I understand everyone tends to get tired at times. Fine. So my humble request that I am available on this number. On WhatsApp for your queries. Fine. So if you have got any query which we could not discuss, uric acid. See, when we talk about uric acid, that is the most common radiolucent stone. Most common radiolucent stone. Fine. Now, see, HCBC, except these stones, hydroxyapatite, fine, cysteine, brucite, calcium oxalate, monohydrate. Except for all these stones, because these stones, they are extremely hard. For all other stones, ESWL is the treatment of choice. Is the treatment of choice. Fine. But for these stones, ESWL is usually not helpful. So we might have to go in for PCML, percutaneous nephrolithotripsy, HCBC. You might want another mnemonic there, CCU. CCU are the stones which are formed in acidic urine. Calcium oxalate, fine. Cysteine, uric acid, fine. Radiolucent stone, the mnemonic is taxi. Triamtrene, the uric acid, the xanthine, the indinavi. Fine. So with this, I would like to bring this session to an end. Fine. Please do your feedback with Rajat sir, like how can we improve the things. If you want anything else, we are always available. Do send your queries on WhatsApp. I'll be able to answer your queries. I mean, I'm sincerely hopeful that I'll be able to answer your queries. Right? Always glad to be with you guys. So glad to be with you. Can we end the class? Can we end the class? Okay, okay. Just a minute. Right. End the class from the OBS, right?